Obsessive-compulsive disorder operates on a cruel paradox. The harder you work to eliminate your anxiety, the stronger the disorder becomes. You experience an intrusive, terrifying thought and respond with a compulsion to relieve the pressure. But that relief is temporary, and the anxiety violently rebounds. Compulsive behaviors function as a false guarantee. They offer a fleeting hit of absolute certainty in a world that is inherently unpredictable. Many patients enter therapy expecting to learn relaxation techniques or coping mechanisms to finally feel calm. But trying to calm the nervous system down actually plays right into the OCD cycle. It reinforces the brain's false belief that the anxiety is dangerous and must be neutralized. Modern clinical treatment requires abandoning this demand for clinical rigidity, the insistence that fear must be absent to function. Instead, the focus shifts entirely to building psychological flexibility. The metric of recovery is not making the fear disappear. It is developing the distress tolerance necessary to experience absolute terror and still refuse to perform the compulsion. This shift in perspective is the foundation of the mastery approach to exposure and response prevention, or ERP, the current evidence-based gold standard for treating OCD. To understand why the mastery approach works, we have to look at the older traditional ERP model. Traditional ERP was built on emotional processing theory, which prioritized a concept called habituation. The core assumption of habituation is straightforward. If you expose a patient to their specific fear trigger for a long enough period without allowing them to perform a compulsion, their anxiety will eventually drain away on its own. Clinical data revealed a major flaw in this model. In practice, a patient's fear does not always reliably drain away during an exposure. More importantly, researchers discovered that achieving a reduction in fear is not actually required for a patient to recover from OCD. This chart illustrates a superior framework, inhibitory learning theory. Instead of erasing the original fear association, the patient builds a competing pathway of distress tolerance. The brain holds both simultaneously. The fear exists, but the new tolerance pathway inhibits the old response from dictating behavior. Under the mastery approach, the anxiety spike may still hit full force, but because the brain has learned that the distress is tolerable, the behavioral urge to perform a compulsion is neutralized. The clinical data backing the shift comes from recent empirical studies, notably a major trial conducted at Humboldt University in Berlin by Elsner and colleagues. The researchers isolated the mechanics of ERP by testing patients during their first, highly standardized exposure sessions to determine exactly what variables led to recovery. They pitted two competing metrics against each other: habituation, measuring if the fear dropped, and expectancy violation, measuring what happens when a patient survives a fear they predicted would be unbearable. Expectancy violation is the exact gap between a patient's catastrophic prediction of an exposure exercise and the actual reality of surviving it without resorting to compulsions. The study revealed a disruptive finding. Within session habituation, the actual dropping of anxiety levels did not predict whether a patient would achieve early remission from their symptoms. Expectancy violation was the primary predictor of early remission, carrying a 2.03 odds ratio that outpaced habituation. For every unit increase in overestimated fear, remission chances doubled. But in the second session, this correlation inverted, proving the first exposure is a critical learning window. The clinical objective during that first exposure is not to calm the patient down. The objective is to deliberately trigger a massive mismatch between their fearful expectations and reality.
Achieving that expectancy violation requires precise clinical tools. The foundation of this process is the fear hierarchy. A fear hierarchy ranks a patient's specific triggers using subjective units of distress, or SUDs, on a scale of 1 to 10. The first rule is strict. You never start an exposure at a SUDS level of 10. Jumping to a 10 overwhelms the nervous system, prevents inhibitory learning, and reliably leads to high dropout rates. The inverse rule is equally strict. You do not start at a SUDS level of 1 either. An exposure rated at a 1 is too easy. It provides zero expectancy violation, and the brain learns nothing. Instead, clinicians target the mid-range, SUDS levels 4 through 6, calibrated for desirable difficulty. This mid-range sweet spot triggers the OCD loop just enough to create a profound learning opportunity, while remaining manageable enough for the patient to successfully practice response prevention. When physical exposures aren't an option, clinicians use another highly structured tool to build mastery, the imaginal exposure script. This narrative tool is deployed when real-world exposure is physically impossible, unsafe, or involves existential fears, such as the intrusive thoughts associated with harm OCD. There are strict structural rules for drafting these scripts. First, the narrative must be written entirely in the first person. Second, it must be written in the present tense. This simulates an environment of immediate and inescapable danger for the brain to process. Third, and most critical, the script must vividly depict the absolute worst-case scenario imaginable to that specific patient. It is a natural empathetic instinct to include safety nets or happy endings in the narrative. That instinct must be ignored. In clinical terms, a safety net functions as a covert mental compulsion. It offers instant reassurance, which immediately neutralizes the expectancy violation and ruins the exposure. The patient executes the tool by reading the document or listening to an audio recording of it repeatedly on a loop. The objective is not to get used to the story. The objective is to intentionally lean into the discomfort and manually spike their own anxiety. Surviving the darkest version of the script, without performing a single mental compulsion to neutralize the fear, is the mechanism that finally rewrites the brain's association with the terrifying thought. These clinical techniques all serve a necessary shift in perspective. The patient must make the active choice to embrace uncertainty. True mastery is not about controlling the internal emotional weather. It is about winning the behavioral battle against compulsions, regardless of how intense the anxiety feels. By utilizing inhibitory learning and building distress tolerance, the patient drives a wedge between the obsession and the compulsion. You are not deleting the fear pathway, but you are creating a reliable barrier that prevents it from dictating your behavior. This work is exhausting. It requires confronting the exact thoughts a patient has spent their life running from, and the courage required to do that cannot be overstated. But despite the pain of the process, the clinical evidence is clear. Leaning into the fear rather than fighting it is the most reliable path out of OCD. Navigating this advanced level of exposure and response prevention requires highly specialized, uncompromising professional guidance to ensure the exposures are calibrated correctly. Edward Jenny and Associates provides that guidance. They utilize an out-of-the-box approach, combining precise psychotherapy with collaborative assessment to accurately target the root mechanics of your OCD. They offer in-person sessions in Kenneck Square, Pennsylvania, and specialized telehealth therapy across the entire state, equipping you with the tools to master your anxiety and reclaim your life.